Hello, welcome to our presentation. This is Group 7, and today we will be speaking about burns. Please enjoy. Types of burns. Friction burns occur when the skin is scraped as a result to rubbing onto a hard object, floor, or concrete. This is mostly seen on motorcycle or bike riders that get into road accidents. Chemical burns is tissue damage that may be caused as a result to products like paint thinner, gasoline, strong acids, drain cleaners, and many other substances. Thermal burns occur when you make contact with heated objects. For example, boiling water, steam, hot cooking oil, hot pots, or hot objects. Cold burns, also referred to as frostbites, occur when you are exposed to freezing temperatures by being outside too long and if the skin is directly exposed to the cold for prolonged periods of time. Examples could be applying cold pack directly onto the skin, direct contact of the snow on the skin for long periods of time. Radiation burns occur as a side effect of radiation therapy or overexposure to ultraviolet lights. Radiation burn can occur as a result to long hours in the sun, tanning bed, radiation therapy, exposure to high-frequency microwave, radio waves, or nuclear energy. Electrical burns occur when the skin comes into direct contact with electricity. When this occurs, the electricity travels through the body, tissue, and organs, resulting being damaged. Next slide.
Classifications of burns. Burns are classified by degree, depending on how deeply and seriously they penetrate the skin's surface. First, second, third, or fourth. It is important for the nurse to understand the differences between each degree so that the nurse can provide the best possible medical care for that patient. First degree superficial burns. First degree burns affect only the external layer of the skin, the epidermis. The burn location is painful, red, dry, and has no blisters. A good example of this is a moderate sunburn. Second degree partial thickness burns. Second degree burns involve the epidermis and part of the lower layer of the skin, the dermis. The burn site looks red, blistered, and may be swollen and painful. Third degree full thickness burns. Third degree burns destroy the epidermis and dermis. They may extend into the innermost layer of the skin, the subcutaneous tissue. The burn site may look white or blackened and charred. Fourth degree burns. Fourth degree burns go through both layers of the skin and underlying tissue, as well as deeper tissue, possibly including muscle and bone. There is no sensation in the area since the nerve endings are destroyed. Signs and symptoms of burns. Burns commonly occur by direct or indirect contact with heat, electric current, radiation, or chemical agents. Burns can lead to cell death, which can require hospitalization and can be fatal. Symptoms vary depending on the severity of the burn. Symptoms are often worse during the first few hours or days after the burn. Symptoms of burns often include blisters, redness, pain, swelling, white or charred black skin, and peeling skin. Some burns are mild and do not need to be professionally treated, like the average sunburn, for example. However, you should see your doctor if you have burns on your hands, feet, face, or genitalia, if you have blistering, if you have burns that don't improve after 2 weeks, if you have severe pain, or if you have a fever, yellow or green discharge, or other signs of infection.
Pathophysiology of burns. So what exactly happens when you get burned? The body experiences heat, which triggers physiological changes that leads to visible skin reactions such as redness, charring of the skin, just to name a few. When the skin and underlying tissue become damaged or burned, this triggers a release of certain chemicals that tell the blood vessels to constrict, which causes cells to separate, known as increased capillary permeability. The blood vessels then become leaky, and the fluid leaks into surrounding tissue, which we visibly see as edema. all the fluid leaks out of the blood vessels and enters surrounding tissue, and this decreases the fluid in the blood vessels. Because there is less fluid going to where it needs to go, for example, to organs, if there is less fluid going into the organs, this also means there's less oxygen traveling to the organs, which can lead to organs not perfusing adequately. Decreased urine output could also be a result to this if the kidneys are not getting enough blood flow. Patients could experience mental status change if the brain is not getting enough blood flow. The GI may also fail as a result if the blood is not traveling where it needs to go. If less blood is going into the organs, the heart will try to compensate and it will start beating faster. But since this is not a heart problem, the problem is with the amount of fluid available. This will further cause blood pressure and cardiac output to decrease. But the heart can't pump enough blood to the organs if there's not enough blood to start with. So then the body will experience two electrolyte shifts, hyponatremia or hyperkalemia. So when you get burned, sodium will travel with fluid that leaks out from the blood vessels. This will decrease sodium in the blood, hyponatremia. Potassium is found primarily inside the cell. So when the cell becomes damaged due to the burn, it breaks. This causes potassium to leak out of the blood vessel, which causes potassium to increase hyperkalemia. Another reaction that occurs in the body is your hematocrit levels will begin to rise as this fluid is lost. Next slide.
There are a number of risk factors for burns. Age-related changes, such as diminished mobility, strength, coordination, sensation, visual acuity, and declining memory, predispose older adults to burn injury. Children under the age of 5 are also at risk. Common injuries among children are electrical burns and hot liquid burns. Men are more likely to experience burn injuries than women, and they are most likely to be burned in the workplace due to fire, chemical, and electrical burns. Burn risk correlates with socioeconomic status. Individuals with lower socioeconomic status are at a higher risk for burns. These factors include poverty, overcrowding, and lack of proper safety measures, such as placement of young girls in household chores. Children and women are usually burned in domestic kitchens containing hot liquids or from cook stove explosions. Firefighters, restaurant workers, construction workers are just some common occupations where burn injuries can occur. Other risk factors are alcohol abuse and smoking, and people with underlying medical conditions, including epilepsy, peripheral neuropathy, and physical and cognitive disabilities. Next slide. NCLEX question 1. A patient is brought to the emergency department from the site of a chemical fire. The paramedics report that the patient has a burn that involves the epidermis, dermis, and the muscle bone of the right arm. When you assess the patient, he verbalizes no pain in the right arm and the skin appears charred. Based upon this assessment findings, what is the depth of the burn on the patient's right arm? A. Full thickness. B. Superficial, partial thickness. C. Deep partial thickness. Or D. Full partial thickness. And the right answer is A. Full thickness. A full thickness involves total destruction of the epidermis and dermis, and in some cases, underlying tissue as well. Assessment and diagnostic tests. The Rule of Nines is an assessment tool used by trauma and emergency medicine providers to determine the total body surface area burn in patients. Measurement of the initial burn surface area is important in estimating fluid resuscitation requirements. The evaluation is made on arrival of the patient to the hospital and should be revised within the first 72 hours. This tool is only utilized for second-degree and third-degree burns. As the photo on the left shows, you can estimate the body surface area of an adult that has been burned by using multiples of 9. The Lawn and Browder chart is considered a more accurate estimation tool to determine the body surface area, especially for pediatric patients. This chart accounts for the differences in proportionality between newborns, children, and adults. The Palmer method is a technique that uses the surface area of the patient's palm, considering to represent 1% of the total body surface area. This method is best used for patients with scattered small burns. Some basic lab studies that should be ordered for burned patients include CBC, chemistry, coagulation profiles, and APGs. Checks X-ray is done on patients when an inhalation injury is possible. CAT scan should also be obtained as indicated with patients with decreased mental status. Next slide.
There are 3 phases of care for a burn injury: emergent resuscitative, acute intermediate, and rehabilitation. The emergent resuscitative phase occurs from the onset of the injury to completion of fluid resuscitation. During this phase, the most important initial priorities of care are airway, breathing, and circulation. It is essential to regularly monitor the patency of the airway during the first 48 hours. Smoke inhalation could cause edema to develop over that period of time and shut the airway down. Excessive secretions could also be a factor. It is then important to focus on fluid resuscitation. Burn victims require more fluid than any other type of injury in order to maintain adequate organ perfusion. However, there is a high risk for over or under resuscitating. There are several formulas that have been developed to prevent that risk as much as possible. The American Burn Association recommends 2 milliliters LR times patient's weight in kilograms times percentage of total body surface area that is burned. The fluids are then adjusted based on the patient's urine output. The goal is 0.5 milliliters per kilogram of body weight per hour. For accurate measurement, a Foley catheter is usually inserted. The patient is at risk of developing hypothermia, so their temperature must be regularly monitored. Pain management is a difficult and important task as well. Medications should only be administered via IV in small, repeated doses. Next slide. The acute intermediate phase occurs from the beginning of diuresis to near completion of wound closure. During this phase, a lot of the emergent care continues. In addition to the risk of upper airway edema and secretions, other complications could develop, such as mucosal sloughing, atelectasis, airway ulceration, pulmonary edema, tissue hypoxia, pneumonia, acute lung injury, and ARDS. Keep the patient's head of the bed elevated and monitor that airway. Body temperature must also continue to be monitored because the patient is at risk for hyperthermia after the initial shock has resolved. They are also at incredibly high risk for infection. Not only is the patient's protective integumentary system compromised, it is during this phase that early excision of the necrotic tissue occurs. This is to preserve the viable tissue underneath and is a crucial medical intervention that lowers the patient's risk for mortality. Keep an eye out for progressive patchy redness of the skin, warmth, tenderness, and a foul smell, which could all indicate infection. Keep the wounds cleaned with mild soap and warm water, and keep the room warm to prevent hypothermia during treatment. Cover the wounds with clean, dry dressings or leave open to air depending on the treatment ordered. Next slide. The rehabilitation phase occurs from major wound closure to the return of the patient's optimal level of mental, physical, and social adjustment. This is a very tough phase and one that lasts for a long time. The patient has made it through the first 2 difficult and sometimes excruciating phases and is now faced with the reality of living with their injuries and the challenges ahead. Treatment-wise, during this phase, we want to prevent scars and contractures. Compression is the key to preventing scars by promoting adequate circulation and collagen restructuring. This is achieved using elastic pressure garments and bandages. Physical, occupational, and vocational therapies are crucial as well. The patient will need a lot of psychological support during this phase. PTSD is often suffered by burn victims along with grief and loss. Providing resources to help these patients is very important after they were released from the hospital and have to take the next steps into their own hands. Next slide. Any wound that is the result of a sizable 3rd-degree burn or requires more than 2 to 3 weeks to heal should be considered for excision and skin grafting to reduce the chances of scarring and infection. Excise the burn down to viable tissue, obtain hemostasis, and apply skin grafts harvested from another site. Wound debridement is the removal of the devitalized tissues. There are 4 types: natural, mechanical, chemical, and surgical. Natural is self-explanatory. No tools are used to assist this process. Mechanical debridement utilizes surgical tools to remove the tissue, while chemical debridement uses topical enzymatic agents. Surgical debridement is performed as soon as possible after the burn and is then covered with a skin graft if necessary and a dressing. Grafting places harvested skin over the wound in order to decrease the risk of infection, prevent further loss of protein, fluid, and electrolytes, and minimize heat loss. Grafted skin can either be from the patient themselves, autograft, from a different human, homograft, or from an animal, xenograft. The preferred method is autograft if possible, so that the skin is not rejected from their immune system. Next slide.
Complications. Acute respiratory failure, or ARDS, are major complications. Patients' respiratory status should be closely monitored for increased difficulty in breathing or any onset of abnormal breath sounds. Heart failure and pulmonary edema may result if the cardiac and renal systems cannot compensate for the excess vascular volume. Sepsis is the leading cause of morbidity and mortality in patients with burn injuries, and this can also lead to septic shock. Infection is also a major complication, as burn wound represents an open site for bacteria. Finally, severe burns can cause long-lasting distress for patients. Burned patients report feelings of anxiety, stress, depression, and lack of confidence and self-esteem. Some patients may also develop post-traumatic stress disorder. Next slide.
Nursing diagnoses for burns. Here are 3 possible nursing diagnoses and appropriate goals for a burn patient. The first diagnosis is deficient fluid volume, related to increased capillary permeability and evaporative losses from the burn wound. The goal for this diagnosis would be to restore optimal fluid and electrolyte balance and perfusion of vital organs. Another diagnosis is acute pain, related to tissue and nerve injury. The goal for this would be to control the patient's pain level. And lastly, we have the diagnosis of ineffective airway clearance related to edema and the effects of smoke inhalation. The goal for this would be to maintain patent airway and adequate airway clearance.
Nursing interventions for burns. For deficient fluid volume, we will monitor vital signs, hemodynamics, and urine output, as well as strict intake and output and daily weight. We will maintain IV lines and regulate fluids at appropriate rates as prescribed. And we will elevate the head of the patient's bed and elevate burned extremities. For acute pain, we will administer IV analgesics as prescribed and assess for effectiveness. We will use the pain intensity scale to assess the patient's pain level. We will differentiate restlessness due to pain from restlessness due to hypoxia. And we will provide emotional support and reassurance. For ineffective airway clearance, we will maintain a patent airway through proper patient positioning, removal of secretions, and artificial airway if needed. We will provide humidified oxygen as prescribed and encourage the patient to turn, cough, and deep breathe. We will encourage the patient to use incentive spirometry and suction as needed. Next slide. Now with your NCLEX question. A 23-year-old male client who has had a full-thickness burn is being discharged from the hospital. Which information is most important for the nurse to provide prior to discharge? A. How to maintain home smoke detectors. B. Joining a community reintegration program. C. Learning to perform dressing changes. Or D. Option available for scar removal. Place your answer in the chat box. The correct answer is C. Learning to perform dressing changes. Teaching the patient and their families to perform dressing changes is critical for the goal of progression towards independence. Proper management of burn injury through proper dressing changes helps prevent wound deterioration. Next slide. Patient education for burns. Burn prevention is very important. Some ways you can prevent burns include installing smoke detectors in all living areas and developing an escape plan in case a fire occurs. It is important to cook safely by keeping children out of the kitchen and keeping hot items towards the back of the counters. Ensuring water heaters are kept at 120 degrees Fahrenheit limits the potential for scald burns to occur. Using long or frayed extension cords can be a fire hazard and should be replaced. You should keep the area surrounding a space heater clear of any flammable materials and away from the reach of children. Lastly, to prevent burns, be cautious when having lit candles as they can lead to fires. What should you do after a serious burn occurs? Stop, drop, and roll. You want to make sure you stop the burning process. Be sure to remove all burned clothing to prevent a deeper injury from occurring. You should pour cool water over the burned area for 3 to 5 minutes. Do not pack the burned area with ice and be sure to remove all jewelry, belts, and tight clothing because burned areas will swell. Cover burns with a clean, dry bandage or sheet and seek medical attention immediately. Next slide. Here's a picture of our trifold brochure that we would provide to our patients who experience burns. It goes over some important things that you need to know about burns, such as signs and symptoms, when to see a doctor, and provides the patient with our location, operating hours, and our references. Next slide. On the other part of our trifold brochure, it discusses the types and classifications of burns, some risk factors, assessment and diagnostic tests, some complications that may occur from burn injuries, and types of surgical management for burns, such as wound debridement and grafting. Next slide. NCLEX question number 3. A patient is in the acute phase of burn management. The patient experienced full-thickness burns to the perineum and sacral area of the body. In the patient's plan of care, which nursing diagnosis is priority at this time? A. Impaired skin integrity. B. Risk for fluid volume overload. C. Risk for infection. Or D. Ineffective coping. I'll give you a couple seconds to answer. The correct answer is C, risk for infection. Next slide.